Welcome, everybody. Today we're doing a deep dive foundational review of respiratory anatomy and physiology. I know we did that in one lecture a couple weeks ago, but we're going to add to it with some more complex physiology. So we'll do a quick brief review. Um, and I want to be upfront about why this lecture matters more than it might seem at first glance. Everything we do in critical care transport, every ventilator setting, every medication choice, every intervention for a hypoxic patient is grounded in the physiology that we're covering today. We're going to move through the anatomy of the upper and the lower airway, also alveolar gas exchange, the mechanics of breathing, thoracic pressures, cellular respiration, including the Krebs cycle, and the oxygen hemoglobin dissociation curve. This is the physiologic language of critical care, and I want every one of you fluent in it by the end of this session. It's kind of a joke. Here are our learning objectives for today. First, I want you to be able to identify the key anatomical structures of the upper and lower airway and explain their clinical relevance. Not just name them, but tell me why they matter and when I'm managing an airway. Second, I want you to describe alveolar gas exchange using Fick's law, again, conceptually, not mathematically. And then third, I want you to explain the mechanics of breathing and thoracic pressures across the breathing cycle, because this is the foundation for understanding how mechanical ventilation works and what positive pressure does to the body. Fourth, I want you to trace the Krebs cycle and electron transport chain at the level of what goes in, what comes out, and what stops working when oxygen disappears. And fifth, I want you to read and apply the oxygen hemoglobin dissociation curve, including shifts, right and left, and interpret an ABG using a systematic approach. Let me first walk you through the upper airway from top to bottom. Again, this will be review. The nasal cavity is our first line of defense. It warms, humidifies, and filters inspired air through the turbinates and the ciliated mucosa. This is why nasal breathing is physiologically superior to mouth breathing, and why intubated patients who bypass this entirely need heated, humidified circuits on their ventilators. The nasopharynx and the oropharynx share the airway and digestive pathways below the soft palate. This is the zone where aspiration risk lives. The larynx is the gateway to the lower airway, and the epiglottis is its guardian. It deflects food and liquid away from the glottis during swallowing. And when you're intubating and working at this level, and understanding the anatomy of the glottis, the arytenoids, the vocal cords, the vallecula, that's what allows you to do it successfully. The cricothyroid membrane, just below the thyroid cartilage, is the emergency surgical airway access point when everything else fails. Transport relevance for an upper airway injury, for angioedema, foreign body obstruction. All of those can cause sudden complete obstructions, and then bypassing those with endotracheal tubes, surgical airways, things like that. Those are what you need to be aware of and know how to do. Quickly moving on down to the lower airway, we've got the trachea, which runs about 10 to 12 centimeters from the cricoid cartilage to the carina. In adults, the carina sits at roughly the T4 to T5 level, which corresponds to the angle of Louis on the chest wall. When you place an endotracheal tube, you should target 2 to 3 centimeters above the carina, confirmed at 21 to 23 centimeters at the lip in most adults. Some literature will say adult females 19 to 21 centimeters at the lip, adult males 21 to 23. But if you're in that neighborhood, then you're likely in a good spot. The right main stem bronchus is shorter, wider, and more vertical than the left one. So, of course, that's why a tube advanced too far almost always goes into the right main stem, and why aspirated objects preferentially end up in the right lower lobe. Beyond the main bronchi, the airways branch through the bronchial tree. We have lobar, segmental, subsegmental, and so on, becoming smaller with each generation until they reach the terminal bronchioles, and finally the respiratory bronchioles and the alveolar ducts. The alveoli, and it's estimated that adult lungs have somewhere in the ballpark of 300 to 500 million alveoli. Those provide the massive surface area required for efficient gas exchange. Type 1 pneumocytes form the thin wall across which gas diffuses. Type 2 pneumocytes produce surfactant, which reduces surface tension and keeps the alveoli from collapsing at end inspiration. Now let's get into some more nitty gritty. We'll go a little deeper. Let's talk about alveolar gas exchange. Alveolar gas exchange is governed by Fick's law of diffusion, and I want you to understand the four variables that determine how efficiently oxygen crosses the AC membrane, or the alveolar capillary membrane. Diffusion rate increases with surface area, which is why alveolar destruction in conditions like emphysema or flooding in conditions like ARDS reduce oxygenation. It increases with the pressure gradient, which is why supplemental oxygen increases P little AO2, or arterial oxygen pressure, by raising alveolar oxygen partial pressure. It increases with the solubility of the gas. CO2 is 20 times more soluble than O2, which is why CO2 retention usually reflects a ventilation problem rather than a diffusion problem. And diffusion rate decreases with membrane thickness, which is why conditions like interstitial or pulmonary fibrosis, edema, or ARDS-associated membrane damage impairs gas transfer. The alveolar capillary membrane is only about 0.5 micrometers thick under normal conditions, incredibly efficient. Gas exchange is so effective that under normal conditions, blood is fully oxygenated in the first third of its transit through the pulmonary capillary, which is pretty impressive. So the Fick's law of diffusion is the diffusion rate, which is surface area times pressure gradient times solubility divided by the membrane thickness. Basically, if you understand the relationship between the two, then the equation becomes pretty irrelevant. Most of the parasympathetic processes, the behind the scenes things in our body that just kind of happen without us even realizing, digestion, things like that. If you think about breathing and the mechanics of breathing, along those lines, it becomes we take it for granted. So understanding the actual mechanics of breathing is vital. So breathing mechanics are the physiologic foundation for everything we do with mechanical ventilation. And I want to be very precise here. Normal, spontaneous breathing is a negative pressure process. The diaphragm contracts and descends. The thoracic volume expands. Pleural pressure drops. Alveolar pressure drops below atmospheric pressure, and air flows in, always going from high pressure to low pressure gradients. Every time we breathe, all of those things occur. Expiration at rest, so exhaling, is entirely passive. The diaphragm simply relaxes. Elastic recoil of the lung and chest wall drives air out, and no muscular effort is required. This changes with forced expiration or obstructive disease, where internal intercostals and abdominal muscles are recruited. Now, here's the critical concept for transport. Mechanical ventilation does the exact opposite. It delivers air by pushing a positive pressure into the airway, a completely different physiologic model. This reversal has consequences. Positive pressure reduces venous return, increases right ventricular afterload, and it can cause barotrauma and volutrauma and rheotrauma and all the other things if pressures or flows or volumes are too high. Every vent decision made needs to account for this difference between positive pressure breathing from mechanical ventilation and negative pressure breathing from spontaneous ventilation. One of the more complicated aspects of the whole breath process is thoracic pressure and the different types of pressure, transpulmonary, etc. So let me walk you through the thoracic pressure values that drive normal breathing. These numbers come up constantly in critical care and on certification exams. Pleural pressure, the pressure in the potential space between the visceral and the parietal pleura, is normally about -5 centimeters of water pressure at rest. During inspiration, it drops to about -8 centimeters of water pressure, creating the pressure gradient that expands the lung. Alveolar pressure is 0 at rest, equal to atmospheric pressure in normal, healthy adults. During inspiration, when you breathe in, it drops to about -1 centimeter of water pressure, just enough to drive flow into the lung. During expiration, when you breathe out, it rises to about +1 centimeter of water pressure to drive air out. The transpulmonary pressure is the difference between alveolar and pleural pressure. It's the pressure keeping the lung inflated and open. When pleural pressure rises, as in tension pneumothorax, things like that, where air accumulates in the pleural space, the lung collapses because the transmural pressure gradient is lost. When I add PEEP on a ventilator, I'm increasing alveolar pressure at end expiration to prevent alveolar collapse and maintain gas exchange. The equations for all the different pulmonary pressures are likely not things that you need to know specifically, but understanding the mechanics of it is very important when you're dealing with any kind of assisted or assisted mechanical ventilation. Anytime we talk about the airflow going into and out of the lungs, with regards to pressure and volume and flow, we always take into account the patient's compliance and resistance. Compliance and resistance itself is a very long lecture. So we'll just kind of hit on the basics of it and go from there. So compliance and resistance, they're the two mechanical properties of the respiratory system that determine how hard the patient or how hard the vent has to work to move air. Compliance describes the stretchability of the lungs and the chest wall. It's the change in volume per unit change in pressure. High compliance means the lungs inflate easily with minimal pressure. This is what you'll see in emphysema patients, where the destruction of the elastic tissue in the alveoli and the distal lung fields, makes the lungs very floppy. So they're over distended, easy to have auto peep. They're just kind of blown. Low compliance, the opposite, means that the lungs are stiff and require much higher pressures to inflate. Restrictive diseases in particular, like ARDS, pulmonary edema, pulmonary fibrosis, those all reduce compliance dramatically. On the vent, you'll see low compliance as high plateau pressures for a given tidal volume. I don't believe you'll really ever need to do plateau pressure in the field, so I'll talk with Dan to see if he wants me to go over that in lab at all. But just so you're aware of the terminology, okay? Resistance, on the other hand, that describes the opposition to airflow in the airways. It increases, resistance increases with bronchospasm, with secretions, with kinked tubing, with water in the tubing, with secretions, anything in the airway, anything in the tube, a narrow endotracheal tube, all of those things increase resistance. High resistance shows up as an elevated peak inspiratory pressure, or PIP, on the vent with a normal or a near normal plateau pressure. Um, The difference between your peak pressure and your plateau pressure is the pressure consumed overcoming resistance. Understanding this distinction guides troubleshooting when you're having issues with the vent and need to determine whether or not the issue causes are a compliance issue from the patient or a resistance issue, either from the patient or from the circuit or the tube. Let's all take a trip back to memory lane. Um, Microbiology, all of our favorite. Not my favorite. Not my favorite at all. However, very important, obviously. So let's talk about cellular respiration. So the big picture for cellular respiration. Again, very complex process, but having a general understanding or idea of it can really help with your clinical assessment while you're in the field. Cellular respiration is the process by which every cell in the body converts glucose into ATP, the usable energy currency that powers every cellular function. I want you to think about this not as biochemistry for its own sake, but as the chain of events that breaks down when your transport patient is in shock. Cellular respiration has three stages: glycolysis in the cytoplasm, the Krebs cycle in the mitochondrial matrix, and the electron transport chain on the inner mitochondrial membrane. Glycolysis requires no oxygen. It's always running behind the scenes. The Krebs cycle and the electron transport chain, those both require oxygen. They're the aerobic stages that produce the vast majority of ATP in the cells. The key takeaway is that when oxygen delivery fails, whether from hypoxia or anemia or inadequate cardiac output or cellular poisoning, the Krebs cycle and the ETC, they shut down. The cell falls back on glycolysis alone, producing only 2 ATP per glucose instead of the 30 to 32, which it normally would do with proper oxygenation. The byproduct of this is lactic acid, which spills into the bloodstream and produces the elevated lactate that you use to identify and track tissue hypoperfusion in cases of shock. So lactic acidosis, when we draw blood gases and run them and get the results, we'll get the if you put in that you want that result, ABGs will give you the lactate, and understanding the importance of lactic acid, in particular lactic acidosis, especially when combined with the respiratory acidosis. The lactate levels themselves, as they climb, they can give you a really good indication of just how hypoxic the patient is at that cellular level. Um, and whenever you're looking at the relationship between them, so O2 det, so when the oxygen delivery, the DO2, and we won't do the equation for that, when that falls below the demand, or the VO2, the tissues switch. They switch from aerobic to anaerobic. They go from the ATP generation to just straight up glycolysis, and that essentially shuts down their ability to receive and transport oxygen. Let's go through each of these phases, and I won't go on too long about them because they're more just FYI. So glycolysis, that's the first stage of energy production and the only stage that doesn't require oxygen. One molecule of glucose, which is a 6-carbon sugar, if you remember the chemistry composition, is split into two molecules of pyruvate. In the process, the cell nets 2 ATP and produces 2 NADH, which carry electrons to the electron transport chain. The key branch point is what happens to the pyruvate. I can't say that word very well, I apologize. Pyruvate? Probably pyruvate. Either way, not in my everyday vocabulary. Um, so if oxygen is available, then the pyruvate, that sounds better, is converted to acetyl CoA by, are you ready for this? The pyruvate dehydrogenase complex, and it enters the Krebs cycle in the mitochondria. So this is the aerobic pathway. If the oxygen is not available, the pyruvate is converted to lactic lactic acid instead. This lactate conversion is not just a waste product; it regenerates the NAD plus that the glycolysis needs to keep running. So in the absence of oxygen, lactate production is what keeps glycolysis, and therefore any ATP production at all, going. This is why lactate is both a marker of anaerobic metabolism and, paradoxically, a fuel source for organs like the heart and liver during recovery. Moving on to the Krebs cycle. The Krebs cycle, also called the citric acid cycle, is the central hub of aerobic metabolism, and I want you to understand it in terms of inputs, outputs, and what happens when it stops. Each turn of the cycle starts with that acetyl CoA entering and joining with oxaloacetate to form citrate. That's a mouthful. The cycle then proceeds through 8 steps, releasing 2 molecules of CO2, generating 3 NADH, 1 FADH2, and 1 GTP. All of that equates to around 1 ATP. Okay, the NADH and the FADH2 are the real prize. They carry high energy electrons to the electron transport chain, where most of the ATP is actually produced. The CO2 released is carried in the blood to the lungs and then exhaled. This is where our ventilatory CO2 removal comes from. For each glucose molecule, the cycle turns twice. Two pyruvates yield two acetyl-CoAs, two terms net 6 NADH, two FADH2, and two GTPs. The cycle can't run without oxygen, not because oxygen participates directly in it, but because NADH and FADH2 cannot be oxidized back to their original NAD plus and FAD without the electron transport chain, which requires oxygen as its final electron acceptor. The electron transport chain is where most ATP is actually produced and where oxygen plays its essential irreplaceable role. The NADH and the FADH2 from glycolysis and the Krebs cycle donate their electrons to a series of protein complexes that are embedded in the inner mitochondrial membranes of the cells. As electrons pass through the chain, they drive proton pumping across the membrane, creating a gradient that powers ATP synthase, the molecular motor that produces ATP. At the end of the chain, oxygen accepts the electrons and combines with hydrogen to form water. Without oxygen as the final electron acceptor, the entire chain backs up, the NADH and the FADH2 accumulate, and ATP production drops to the minimal output of glycolysis alone. The net ATP yield from one glucose molecule under fully aerobic conditions is approximately 30 to 32 ATP. Glycolysis alone under anaerobic conditions yields only 2 ATP. This is a 15-fold difference in energy output without oxygen, and that's why oxygen deprivation, whether from hypoxia or shock or carbon monoxide poisoning, causes such a rapid and severe cellular dysfunction. So when we talk about oxygen transport in the blood, it's not just about the saturation or the SpO2. It's about the total amount of oxygen delivered to tissues, which depends on three factors: hemoglobin concentration, hemoglobin saturation, and cardiac output. The oxygen content formula is, and these equations you're not going to need to know. RTs have to memorize them, but this is more just FYI. So the oxygen content formula is CaO2 equals 1.34 times the hemoglobin times the SaO2 plus 0.003 times the PaO2. That's a mouthful. The 1.34 factor is the oxygen carrying capacity of hemoglobin in milliliters per gram. The 0.003 times the PaO2 term represents dissolved oxygen, which is tiny under normal conditions, but becomes relevant when patients are in like hyperbaric oxygen therapy. The clinically crucial implication, though, is that a patient with a hemoglobin of 7 and an SpO2 of 100% has far less oxygen content than a patient with a hemoglobin of 14 and a SpO2 of 95%. Right? This is why you should treat anemia as an oxygen delivery problem, not just a number on a CBC. Okay? Cardiac output multiplies this content to give oxygen delivery, the DO2. DO2 equals your CO times your CaO2 times 10. When cardiac output falls, like in shock, oxygen delivery falls proportionally, regardless of what the pulse oximeter shows. The relationship between oxygen and hemoglobin is essential in respiratory care and in critical care transport medicine. It's one of the most clinically important graphs in respiratory physiology, and I want you to be able to, at least be able to read it and interpret it a little bit, ideally without hesitation. It's not like you're going to see this in the field, but understanding um, what it is and what causes a right shift versus a left shift is important in your clinical understanding of the patient. So the curve itself plots hemoglobin saturation, so the SaO2 on the y-axis, against the partial pressure of oxygen in the arteries, so the P little AO2 on the x-axis. The kind of sigmoid shape is not arbitrary. It reflects the cooperative binding behavior of hemoglobin. As each molecule of oxygen binds to a hemoglobin subunit, it slightly changes the shape of the molecule and makes the remaining subunits bind oxygen more easily. This is why the upper portion of the curve is flat. In the lungs, where the PaO2 is high, hemoglobin loads oxygen efficiently, even with modest drops in PaO2. And the steep lower portion of that curve is equally important. In the tissues, where the PaO2 is lower, small drops in partial pressure can cause large releases of oxygen to the cells that need it. The P50, and I don't think you can see my cursor, but that's about a quarter of the way up the slope there. That is the PaO2 at which hemoglobin is 50% saturated, and that's normally around 27 millimeters of mercury. This is the reference point for the curve shifts as they go away from baseline, either left or right. So when a patient's ability to oxygenate is impacted based on disease process or trauma, the shift in that oxygen hemoglobin dissociation curve is either going to be to the right or the left. The shifts of the oxyhemoglobin curve, though those are high yield exam content and even higher yield clinical knowledge. So you may very well even see this on your placement exam. So a right shift means that the hemoglobin releases oxygen more readily because the affinity is lower. Mnemonic would be cadet. Cadet, face right. So whenever you have an increase in CO2, an increase in acid, so the pH, so if the pH decreases and or the PaCO2 increases, that causes a shift to the right in the curve. If you have increased 2 to 3 dpg, anytime you exercise, whenever temperature, body temperature is increased, all of those things shift the curve to the right. Physiologically, these are exactly the conditions present when you exercise or metabolically stress your tissues. The curve shifts right precisely when and where oxygen needs to be offloaded. A left shift, on the other hand, means hemoglobin holds on to oxygen more tightly and the affinity is higher. This occurs with decreased CO2, alkalosis or increased pH. So a hyperventilating patient, increased pH, decreased PaCO2, that will shift your oxyhemoglobin curve to the left. Temperature, body temperature, as that decreases, that causes a left shift. Carbon monoxide causes a left shift. The left shift is generally unfavorable for tissue oxygen delivery because hemoglobin loads well in the lungs but fails to release it at the tissues. Carbon monoxide, I'm sure you see plenty of those patients. Carbon monoxide deserves special attention. It shifts the curve left, and it occupies hemoglobin binding sites directly. So that's a double threat. That's why CO poisoning is so dangerous, even at SpO2 values that look normal on standard pulse ox. So whenever you have a patient with suspected CO poisoning, you'll put the pulse ox on. It'll very likely read high, but know that their actual PaO2, the arterial partial pressure of oxygen, the actual amount of oxygen being loaded and unloaded at the cellular level, at the tissue level, that is almost always very low. It does not correlate with the pulse ox. So CO patients are deceptive in that they often are extremely hypoxemic, although the pulse ox reads normal. So anytime you have a patient with CO, suspected CO poisoning, just flush them with oxygen to cover yourself. All right, taking it a step further, I know this is getting kind of deep in the weeds, but um, maybe something will stick. When we talk about CO2 transport, so carbon dioxide transport, and your acid-base fundamentals, those physiologies are very tightly linked. And you as the transport clinician control one side of the equation directly through ventilator management. CO2 is transported in the blood in three forms. It's dissolved in plasma, about 5 to 7% of it, as compounds bound to hemoglobin, about 23%, and most importantly, as bicarbonate, or the HCO3 portion of the blood gas results, about 70%. When CO2 enters the blood from the tissues, it rapidly combines with water to form carbonic acid via carbonic anhydrase in red blood cells. Carbonic acid dissolves into positive hydrogen ions and bicarb. The positive hydrogen ions are buffered. The bicarb shifts into plasma, and the CO2 is effectively transported as bicarbonate to the lungs. There's a Henderson-Hasselbalch equation that describes the equilibrium. Won't quite get into that. But for transport purposes, the practical implication is direct. You control the PaCO2 of the patient through the ventilation rate and the tidal volume. Increasing the respiratory rate or the tidal volume blows off more CO2, which raises the pH and lowers the PaCO2. That's useful for both respiratory and metabolic acidosis. Decreasing the rate or the tidal volume retains more CO2 and drops the pH, which you might accept in permissive hypercapnia for COPD patients, or if you're doing any kind of lung protective ventilation strategies. Another thing to keep in mind when you're thinking about the way that oxygen is transported and shifted throughout the body is VQ. So VQ is ventilation to perfusion. The V is ventilation, the Q with a dot over it is perfusion, and we look at the relationship between those two things, not just for giggles, but to be able to identify clinically what's going on with the patient. So VQ is a ratio, okay, and so a normal V or ventilation is 4 parts. Normal perfusion is 5 parts. So, and then 4 to 5, 4 divided by 5 becomes 0.8. So a normal VQ is 0.8. Anything that increases or decreases the VQ causes a mismatch. Whenever there's a VQ mismatch, then we need to pay attention. Um, the ventilation perfusion matching is the concept that explains why some patients don't get better when you give them oxygen. And helps to understand that it separates good, transport clinicians from great ones. In a normal lung, ventilation and perfusion are matched. Areas that are ventilated are also perfused, so gas exchange is efficient. Whenever you have a VQ mismatch, that occurs on a spectrum. At one extreme is dead space, where you've got lung units that are ventilated but not perfused, as in the pulmonary embolism. Um, Dead space wastes ventilation and causes hypercapnia and hypoxemia. At the other extreme is a shunt. Those are lung units that are perfused but not ventilated. So when you have consolidation, atelectasis, uh, secretions, any flooded alveoli and ARDS, those create shunts or shunt-like effects um, that lead to refractory hypoxemia, which is when the PaO2 on the blood gas is less than the FiO2 delivered to the patient, because the blood passing through the unventilated units never has the opportunity to pick up oxygen, regardless of what FiO2 you deliver. So increasing FiO2 for patients who are refractory does not really ever do anything. You need to increase PEEP to increase the alveolar surface area to allow for better transfer. The treatment for shunt, it is PEEP, 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 PEEP. Anytime you have any kind of shunt-like effect within the lung, PEEP is the best way to treat that underlying cause and improve the lung mechanics. That's one of the most important clinical applications of VQ physiology that you should use in transport. So when you think about ventilation perfusion, the ventilation, if there's an impairment with the ventilation, that creates a shunt. So think of like if the alveoli are shut, that's a shunt. Shut, shunt. Um, if it's a vascular issue dealing with um, any of the blood vessels, going around, coiling around the alveoli, if that's impaired, if it's a blood flow issue, then that creates dead space. So space that's dead, space that um, oxygen won't be able to transfer over to, because the blood flow itself, whether it's a hemoglobin issue or a flow issue for cardiac output, or any number of things. If it's a cardiovascular impairment, then it creates dead space. Um, so understanding based on the patient's history and diagnosis and condition, whether it's a shunt or dead space that's causing the hypoxemia, is important to think about so that you can know how to treat it. All right, let's go over the four types of hypoxia. So this should be reviewed, so I'll kind of blow through it. Four different types of hypoxia: hypoxemic, anemic, stagnant, and histotoxic. Okay, those describe the four different failure points in oxygen delivery and utilization. And recognizing which type you're dealing with changes your treatment completely. So hypoxemic hypoxia on top, that is a low PaO2, so low partial pressure of oxygen in the arteries. The lungs are not getting enough oxygen into the blood. Treatment for hypoxemic hypoxia is pretty self-explanatory. You give them more oxygen, increase the PEEP, or indirectly by improving ventilation to allow for better exchange. Anemic hypoxia is different because you just have low functional hemoglobin. So the SpO2 will read normal, um, but it's got a reduced carrying capacity. So think about the hemoglobin curve shifting left and right. So there's not enough hemoglobin or dysfunctional hemoglobin as in CO poisoning or other conditions that would create that. The SpO2 itself can look normal, even as oxygen content and delivery are critically reduced. Treatment is blood transfusion for anemia or specific antidotes for CO and methemoglobin. Um, Stagnant or circulatory hypoxia, that's when you've got inadequate cardiac output. Cardiac output, of course, being heart rate times stroke volume. In the case of circulatory or stagnant hypoxia, the oxygen is there, the hemoglobin is there, but the blood isn't moving. So treatment is addressing the cause of the circulatory failure. So you may need to add fluids or pressors or inotropes and things like that. And then finally, you've got tissue hypoxia or histotoxic hypoxia. That's kind of the most insidious of the four. Um, the oxygen delivery is normal, but the cells themselves, tissue cells, they can't use it. So anytime you've got something that will override or prevent cells from using oxygen appropriately, like in cyanide poisoning or hydrogen sulfide poisoning, um, though those are very deceptive. The treatment is the specific antidote for whatever poisoning there is. Um, so the SpO2 in cases of histotoxic hypoxia is often normal or elevated, a clue that something is blocking the cellular respiration downstream. And the CCTP exam frequently tests the ability to differentiate hypoxia types and select the correct intervention. So understanding if it's a PaO2 issue, then it's likely hypoxic or hypoxemic hypoxia. If there's a normal SpO2, but the hemoglobin is low, and you've got some anemia, so anemic hypoxia that requires giving fluid, blood. Um, and you want to give them a O2 flush for that, 100%. Circulatory hypoxia, that's with the pump, heart rate and stroke volume for your cardiac output. So um, fluid management becomes essential at that point in order to be able to decrease the delivered FiO2 and improve cellular oxygenation. And then the tissue hypoxia there, that's where everything is fine and dandy from the lungs, but the tissues downstream themselves, they can't do anything with the oxygen because they're invaded by some other chemical, some other thing. So that's your cyanide and hydrogen sulfide poisoning. I threw an ABG interpretation slide in here. I know I did this in another um, lecture, but as I was going through and kind of remaking it, I thought that this table might be helpful for you, so I put it in here. Let me close with the concepts that I want you to carry with you from this really dense, um, I guess 50-minute lecture now. So the respiratory system moves gas, and the cardiovascular system delivers it. Both must be functioning for oxygen to reach the cells. The CO2 removal is a ventilation problem. You control it with the respiratory rate and the tidal volume. Oxygen delivery depends on the FiO2, the PEEP, the hemoglobin concentration, and the cardiac output. A normal SpO2 does not mean adequate oxygen delivery on the surface. The Krebs cycle and the electron transport chain are the engines of the aerobic metabolism. When oxygen fails, they stop. Glycolysis provides only 2 ATP per glucose, and lactate rises as the signal, signaling the problem. The oxyhemoglobin dissociation curve is not just a graph, it's a physiologic tool that explains why tissues get oxygen in the right places at the right times and why shifts matter for your patients. And the 4 types of hypoxia should remind you that all oxygen problems, or not all oxygen problems, I'm sorry, not all oxygen problems are solved just by giving more oxygen. Knowing the mechanism that guides is what guides the treatment. So understanding where the true issue lies. The physiology is the language of critical care transport, and hopefully now you can speak it with relative fluency. Thanks.